A few seconds to take your seats. Right in the middle. There we go. My name's Sarah Chapelski, and thank you so much for joining us today for this Pediatrics mini review. I'm really excited for the group of speakers that we have upcoming, both as a physician, but honestly, mostly as a mother of young children. So I'm really looking forward to it. I am joined today by Dr. Stasia Hagianakis, who is going to introduce our first speaker.
Thank you. Thanks, Sarah. It's a real pleasure to be able to introduce our first speaker, a generous colleague and friend. Dr. Katherine Morrison is a pediatric endocrinologist, professor in the Department of Pediatrics, and co-director of the Center for Metabolism, Obesity, and Diabetes Research at McMaster University. She is a clinical researcher, active clinically in the pediatric weight management and pediatric lipid clinics at McMaster Children's Hospital. She will speak to us today about the health of Canadian children enrolled in pediatric weight management programs, lessons learned from the CANPWR study. Please join me in welcoming Dr. Morrison.
Thank you very much, and thanks to the organizers also for inviting me to come and speak to you this morning. I have a few objectives that I hope you will take away from today. Really the main thrust is for you to understand who we're seeing in treatment programs for children in Canada. I want you to think about health broadly, and to touch on that, I'll work through the Edmonton Obesity Staging System for Pediatrics, and then to reflect on those in terms of what we're seeing in the CANPWR study. Before I start talking about health outcomes in kids, I want to tell you a little bit about CANPWR. Those of you who are pediatricians across the country may be aware that there are a number of pediatric weight management clinics, and quite a number of years ago now, a group of us got together to try and do some collaborative work, and we were generously funded to do that, and then that has broadened into the 10 sites who got involved with CANPWR. And the little stars, as you might guess, are where those sites are located. So what is CANPWR? It's an observational study of children at the time. It begins at the time of entry into one of these Canadian pediatric weight management programs. And as I mentioned, the pilot was initially funded by Connectin, which is a CIHR-sponsored funding envelope. And then the main study was funded by CIHR. Is funded by CIHR. The main focus on CANPWR is really to try and understand what is it that we're doing well in our pediatric weight management clinics, and for whom, which children or families seem to be responding. And our definition of responding is based upon a relatively broad definition of health, not just looking at anthropometrics, which is really the bulk of the literature, what we have to this point. So we're looking at what are the anthropometric and obesity-related comorbidities at baseline, how do they change over time, and what are the determinants that are related to that. And then as many of you will know, attrition is one of the biggest issues that we identify in families after they enter weight management. And so trying to understand the baseline determinants or predictors of that. We've borrowed this ecological model, as many have, and you'll see on here the characteristics or the determinants, if you will, that we're looking at in relationship to health outcomes. So we're looking at the characteristics of the child, of the family, and eventually in terms of looking at response to change, we're going to be looking at the characteristics of the programs themselves. So we know that the prevalence of obesity, as you look at this is American data, if you look on the left set of bars, class 1 obesity is relatively stable over the recent years. This is only up to 2012. But the prevalence of severe obesity continues to increase. And this is true around the world, but is based solely on BMI. This is the baseline data of the group that were involved in this EOSP study. It's a subset of the total population because the kids had to be over 5 for us to include them and had to have a full set of metrics that would allow us to measure health outcomes. And what you'll see here on your right is our classic growth chart for BMI. The yellow arrow would be the classification of obesity, and the dark blue arrow is the classification of severe obesity, or 2 standard deviations above the mean. And what we have seen, and you can see from those numbers, is that almost 2/3 of the children, by the time they enter pediatric weight management programs, at least one of these 10, already have a BMI classification of severe obesity. So they're coming relatively late for intervention. What about the health? Well, we know a little bit, especially about cardiometabolic health in children with severe obesity, and in the relative prevalence of issues related to the extent of obesity that children have. And you'll see here that especially things like triglyceride levels are highest or the prevalence of abnormal triglyceride levels is highest amongst those with the most severe obesity, and systolic blood pressure similarly so. But although we know the most about cardiometabolic health and anthropometrics, anybody who works in a pediatric clinic related to pediatric weight management is well aware of the fact that that is not usually the reason why families have presented for care, and certainly does not reflect the health challenges that those families are facing. And with that recognition, building on the Edmonton Obesity Staging System for adults, Dr. Hagianakis, who you've just met, and Dr. Ball, and a group of clinicians across the country pulled together an Edmonton Obesity Staging System for the pediatric age group. And what I want you to focus on here are that I hope you can read that, I know that the writing is tiny, that you're focusing on the metabolic, the mechanical, the mental health, and the social milieu of the individual and their families. And it's graded by stage 0 being that there are no issues identified. Stage 1, there are preclinical or mild abnormalities identified, and stage 2 and 3 are considered moderate and severe. Okay, so the reason I'm telling you that is I want you to remember those 4 M's, both for the rest of my talk, but also as you are thinking about the patients that you're working with in your clinics. So the methods of this study, looking at the baseline data, was to examine the burden of illness amongst obese children and youth when they enter Canadian pediatric weight management programs. And as you might have guessed, we've utilized the 4M framework to do that. It is cross-sectional because it's our baseline visit. It's embedded in the CANPWR study. I didn't previously mention that the data collection for CANPWR is very much based in the clinical environment, but it is standardized and harmonized across sites. Our recruitment was completed for CANPWR towards the end of 2017, and we've utilized that data to do this analysis that has been recently published. So our main question or main focus was to look at comparing these health outcomes using the 4 M's across the classification of obesity based on BMI. This is, you've already seen, and I've put it back up again to show you that we were able to differentiate stages 0 and 1, and stage 2 and 3 we've put together because we didn't have metrics that actually differentiated moderate from severe. These are the children at baseline. I've already reflected on the extent of obesity at the time of entry into pediatric weight management programs. You'll see the average ages are relatively similar across the classes of obesity, and I'm using the WHO obesity class here, so 1, 2, and 3 standard deviations, 2, 3, and 4 standard deviations above the mean. The proportion of males increases with the increasing class of obesity by a little bit, and socioeconomic status. And here we're just looking at income. You'll note that the low income group is more prevalent with class 3 obesity than with class 1. So here's the overall EOSP. So the EOSP, whatever your stage, your highest stage is your overall EOSP classification. And utilizing that, all of the graphs you're going to see are going to be similar. Stage 0 is in dark black. It's a little bit hard to see here because none of the children, or very few, I think there were 11, children in CANPWR had stage 0 or no evidence of any health abnormality at baseline. Stage 1, I've mentioned, and you'll note that, of course, the preponderance of children right across the obesity classes have stage 2, 3, or moderate to severe health issues related to the presence of obesity. So it is not higher in the class 3 than in the class 1. It's relatively equal across classes. But what about the individual 4Ms? This is the metabolic health issues, something that we know a little bit about. And you'll note here that really metabolic issues are slightly, especially stage 2, 3, are slightly more prevalent with the highest class of obesity, but they really are very prevalent across the obesity, the extent of obesity. The most common ones that were identified at baseline include those listed here, not too surprising to any of us really in terms of the findings. Well, what about mechanical health issues? Interesting, these are less prevalent at baseline, so that's important to notice. Although I will put a little caveat in there that sleep apnea especially, it is reported in 9% of the kids on their clinical chart at the time of entry into weight management, but at least in this province, we're waiting sometimes up to 2 years to get a sleep study in our pediatric kids. So that is almost certainly an underrepresentation of the number of children with sleep apnea. At any rate, you will notice if you look at stage 2, 3, or moderate to severe mechanical issues do seem to increase with increasing class of obesity, and I think that is something that we might have expected. What about mental health issues? Mental health issues are extremely prevalent across all of the classes of obesity, and you'll notice that it's about 16% or 15% of children in class 1, moving down to about 10% of children with class 3 obesity who have no mental health concerns at the time of entry into our program. So moderate to severe mental health issues are present in 60 to 70% of these children, and it's relatively stable across obesity class. Anxiety is, and these are identified at baseline, so this is not something that's identified as treatment is progressing, but these are prevalent already when the kids come. The social milieu includes a number of issues. We've already talked about the socioeconomic status and the prevalence of low socioeconomic status increases with increasing obesity. So there are also problems with bullying and peer relationships that are very prevalent in these children. And again, this is based on a baseline initial conversation of the clinic with the family. And in my own personal experience, these become more obvious as time goes on and the families become more, especially the kids, become more willing to open up and chat a little bit about some of the challenges that they face on a day-to-day basis. At the class 3 level, there's a very significant number of children who actually don't attend school because of those issues. So in summary, 2/3 of the children at the time of entering Canadian Pediatric Weight Management clinics have severe obesity based on BMI. The health burden is very high at the time of entry into our weight management programs. Mental health issues are the most common, followed closely by metabolic health issues. And really only the social milieu issues and the mechanical health issues are those that progress or increase in prevalence with the increasing extent of obesity. It raised the question for us as authors of this study, are we defining severe obesity in the appropriate manner for us to actually understand the health issues of these children and their families? I think many of us think not, but we're very intrigued to see how things change over time as the children progress through the programs. And finally, I would be remiss if I did not remind you of all of the people that I'm here representing, and that's the work that's been done at the CANPWR sites by our local coordinating team, and I have a special send out of thanks to all of the investigators who have put their own time and energy into this study, and for Dr. Hagianakis, who was the first author on our paper that was published a couple of weeks ago. So it's been a great team effort, and of course helped out by our study sponsors from a funding perspective. And thank you. I'm happy to address questions.
Thank you, Katherine. That was a great talk. I was just kind of curious about your thoughts about, the necessity. Do you think it's necessary to address the mental health or the social stigma of obesity in these children before initiating the weight management interventions?
That's
What do you
a
think about
fabulous
that?
question, and I think it reflects a lot of what we know is being discussed at this meeting in terms of the levels at which we should. So yes, absolutely, we need to address those things, and I think we need to be addressing them at multiple levels. So from a societal perspective, there's no question that we should be addressing the social stigma pieces, and the bullying piece will be related to that. I think the mental health piece is one that it's incredibly important to identify, and we know as clinicians it's incredibly important to address, perhaps before they enter a weight management program. And I think we're not alone across the country in considering whether a weight management program is the right place to be for some of these kids. We really do begin with some of the mental health piece before we kind of continue on. So absolutely, yes.
One final question.
Yeah, wonderful talk, Katherine. I just wondered, in terms of some of the comorbidities, did you include kids with developmental issues?
Yeah, so I didn't put those numbers up here. There's a lot of numbers, and we're starting to tease them apart a little bit. We're in the process of analyzing the determinants for some of those health outcomes at baseline, which was not part of this. And we took all comers into the CANPWR study that agreed to be part of it. Not all sites, though, will accept children with developmental delay, for example, into their treatment program. And there are some age restrictions. There's a Pecha Kucha coming up in a little bit that compares the health professional approach at the different centers in CANPWR that will address a little bit of that. Thanks, guys.
Our next speaker is Shauna Burke. She is an associate professor in the School of Health Studies at Western University. Her primary specialization is the psychology of health and physical activity, with a special focus on childhood obesity and family health. Please join me in welcoming Professor Burke.
Thank you very much. Again, to the organizers, thank you so much for the invitation to give this talk today. It's really an honor to be here and to be sharing this morning with the other wonderful speakers. So welcome to everybody. I'm here to talk about, and I apologize to those of you that were in the pediatric session yesterday, as this really is a mini review of some of the information I presented yesterday. But I'm here to talk about kind of people who are key stakeholders in the treatment and the prevention of childhood obesity, and that is parents. And in particular, I'm going to be talking a little bit about, of course, childhood obesity, but one approach, which is the family-based intervention approach, and specifically parent-focused interventions. I'm going to touch on two different programs, pilot or feasibility interventions that we ran at Western University over the past decade or so, and then talking about what parents' views or perspectives of those programs are. And then hopefully I'll leave off with some implications and future directions or considerations for those of you that might be interested. We know that childhood obesity is a major public health challenge globally. We also know that there's no singular cause. Like adult obesity, pediatric obesity is associated with many different factors, personal, social, environmental, political, and other. And so for the purpose of today, I'm going to be talking about that family unit and parents in particular as an influence. So the family-based childhood obesity intervention approach really was developed over 35 years ago by Epstein and colleagues who have played a fundamental role in this area. These interventions are developed and implemented in an effort to improve parental support, family interactions and dynamics, and as well as the home environment, typically from a health behavior perspective. Both short and long-term results support their efficacy and pretty consistent over time, although we do know that younger cohorts of children and in some cases females do tend to benefit more. And of course this area has also its limitations in terms of a lack of theory-driven research and some other important limitations. So the primary aim of family-based approaches to the treatment of childhood obesity is to have family members, and in particular parents, lead the facilitation of behavior modification among their children. So really to take on this role as a primary agent of change for children's health behaviors. And indeed, there's an abundance of evidence to suggest that parents really are critical partners in this, and they play a really significant role in both treatment and prevention efforts. And this is for a number of reasons. One being that the family of origin is the first and most influential socialization agent during childhood. We know that parents are role models for lots of different behaviors, health behaviors being no exception. Children emulate parents' lifestyle behaviors. And of course, parents are gatekeepers, right? Parents are the ones who are the primary purchasers of food. They're the primary decision makers about household food and meals and when and where and often how much even children eat. So then parent-focused interventions, which is kind of a subset within the family-based approach, are those that target parents exclusively. So they target parents as the primary agents of change, and it's been found that doing so can really mobilize family resources to improve the efficacy of childhood obesity treatments. So what's unique about parent-focused programs are that the target population, which is still the child, is not directly involved in the intervention itself. There's research suggesting that this type of an approach, where the parent is involved and not necessarily the children, has been found to be at least as effective and in some cases more effective than other traditional family-based approaches where both child and parent are involved. Also, there's some evidence to suggest that perhaps they might be more cost-effective and sustainable in the long run. So I'm going to switch gears a little bit now and talk about these two different interventions that we ran at Western using two different approaches. So about a decade ago, our research team designed and implemented a program called CHAMP. As you can see here with the CHAMP logo, this was the Children's Health and Activity Modification Program. This was a child-focused program. So the kids attended a camp, and I'll talk a little bit more about that. More recently, we designed and implemented a program which was a follow-up called CHAMP Families. This was a parent-focused program where the children were not actually actively involved in the intervention per se. So both were single-center, non-randomized feasibility studies with pretty small sample sizes, and I'll touch on that as well. Community-based treatment programs. So the original CHAMP program, like I mentioned, it was a camp-based program. So kids came to a camp for 4 weeks, Monday to Friday, 9 a.m. to 4 p.m. The parents did have some involvement on weekends for 4 hours. So every Saturday, the parents came to the program throughout that 4-week phase. CHAMP Families, on the other hand, was parent-focused, and it was an educational intervention over the course of 13 weeks where parents attended 90-minute educational sessions. While they did this, children took part in just regular YMCA programming for children at the same time. So again, just highlighting here that the CHAMP program, the original one was high in child involvement, relatively low in parent involvement, whereas CHAMP Families, that model was kind of flipped, where there was lower child involvement, actually no child involvement in the actual formal intervention, and higher parental involvement than the original CHAMP program. You can see here we assessed a number of different outcomes, but for the purpose of today, I'm just going to be talking about parents' perceptions of these different programs. 40 children participated in the original CHAMP program over the course of 2 years, and 16 parents representing 11 kids participated in the more recent CHAMP Families program. So again, for the purpose of today's talk, I'm going to talk about some of the findings from the focus groups that we've conducted with parents who were involved in these different interventions. So we did conduct focus groups at the end of both programs, moderated by members of the research team, about an hour to an hour and 15 minutes, and inductive content analysis for the original program and thematic analysis for the follow-up program were performed. So who took part in these focus groups? In the original program, we had 7 focus groups consisting of 38 parents. And for the CHAMP Families program, we had 2 focus groups with 12 parents in total. We had a number of different themes and sub-themes within each, but again, I'm only going to touch on a few of these for the purpose of today's talk. So we found that overall, and again, I'm not going to get into all of these findings, but parents perceived their participation in both programs to be generally positive. They highlighted several positive health-related outcomes for children, for themselves, for their families, but they also provided some important insights that I'll talk about today regarding their roles, impactful program components, and also their thoughts and recommendations for future programs that we might, or others might implement. So from the original CHAMP program, parents really felt that they had an increased awareness about their role as shaping their child's health behavior and the impact of their own thoughts and behaviors on their children's. They also recognized the importance of serving as a role model for their kids. As you can see here, in order for my daughter to get where she needs to be able to follow my husband and myself so she knows how to get there. Also, it has to be a family thing. Like, you can't just have the kid go and expect them to make the change. I mean, we have to reinforce it, and we have to also want it for ourselves in order to make it work. Also, from a parental role perspective, parents in the more recent CHAMP Families program identified that they felt more confident in their ability to facilitate greater family dynamics. And this was really important because a lot of this related to communication in the family, and parents did identify that they felt more confident in their ability to talk to their children about important issues related to their weight and their health. You can see here with the quotes, the discussion was easier. It was an elephant in the room amongst the family that was just gone. Another said, you always want to protect your children, so sometimes you might see an issue, but you don't want to address it because you're afraid of their reaction. So if you bring everything out in the open and start to talk, then once communication opens up, you can get a lot of feedback and learn what motivates your children. So this was something that parents did struggle with, is how do we broach these conversations? How do we talk to our children about issues that can be really difficult without making any issues that may be existing worse? So parents had a fear around talking about these things and exacerbating anything that might be going on. Another sub-theme that came up within this kind of confidence to promote the health behaviors of children was parents in both programs identified that they felt more confident in their role as serving as an agent of change in their families. So one said, I do feel as though I'm more confident. I can tell her why we're doing what we're doing now. I have more knowledge, so I can pass that to her. Somebody from the original CHAMP program said, empowered. You feel like you have more knowledge to work everything out. Whether it's with nutrition or exercise, you feel like you have some more tools to kind of deal with things. Parents in both programs also felt like they were more capable or had more confidence in, or maybe just recognizing more the role that the child had and the responsibility that the child had towards their own health. So one parent in the more recent Champ Families program said, I think I've learned some things that have helped my daughter or given me the courage to do things a little differently, or let her try things. Let her cook one night and use the sharp knives that I wouldn't have ever thought she was capable of doing. Another parent from the original program said, I think my daughter realizes now that she has the tools to do things, but it's up to her, that you can indeed take responsibility for yourself, and it's up to you to do that. Overwhelmingly in both programs, the majority of parents reflected was that the group environment was so critical to the success of the program. Both programs were developed on the basis of group dynamics theory, using evidence-based group dynamics strategies to promote cohesion and adherence, and also hopefully behavior change. In particular, this sense of community and this sense of belonging, for those of you that were at the physical activity mini review session this morning, this is a common theme. This is something that's so important. Parents really felt that this group environment was important for themselves, but also their children. So from the Champ Families program, again, that was parent-focused, a parent said, the strength of the program is the community feeling that you generate. There were a lot of emotions that parents had, and in there, they are kind of laid out. I think that actually brings the group closer. A mother from the original CHAMP program was talking about the importance of the group for her child. So she said, my son just seems to be a little more self-assured. It was just being in the group. I remember the first week he said to me, Mom, everybody belongs. I just know that I'll fit in. Again, related to the group environment was this issue of interaction and support. One mother said, I love the fact that it's a support group for families. It's good to see that there's something going on that helps parents get together and learn from others. And this was something that was identified by parents as lacking in the London community, and something that they appreciated. A CHAMP participant said, I feel like I'm not alone. It's a nice feeling to know there are so many other people out there just like me. We're really feeling comfortable as a group, and I got the feeling that I can do it. It's not just me. Now, in terms of recommendations for future programs, participants in the CHAMP program, again, which was primarily child-focused, wanted or identified that they had a desire for more involvement themselves in the program, more parental involvement. I would have preferred to have done all of it, attending camp with my child. I think we would have benefited from doing it, the family sessions as a family together. There should be a CHAMP camp for parents. Parents in this program also identified that they wanted more accountability, only to be made more accountable. I looked at it afterwards, every day they bring something home, and yeah, we're supposed to sign this and look at this. I didn't do that to the extent I should have. I think most parents in the room can also relate to this, this type of sentiment. Now, parents that were involved in the parent-focused program, the more recent Champ Families program, they identified that they actually wish that their children were more involved in the program. So if a peer group similar to this could be made for kids. So because parents really identified a strong appreciation for that group and the importance of that group support, they wanted that for their children as well. Another one said, take it one step further. If the kids were a little more involved along the way, something child-focused so they can feel even more proud of their accomplishments and share amongst their peers too. So where does this leave us? moving forward. We have lots of work to do moving forward, but I think in terms of some similarities, parents in both programs noted several benefits for their children, for themselves, for their families. I think together, parents in both groups really underscored the importance and positive impact of the group environment. This is not new. There's lots of evidence to support that, using the group as an agent of change in lots of different health behaviors is very effective. Regardless of the fact that parents in the child-focused program wanted more parental involvement and parents in the parent-focused program wanted more child involvement, I think one thing is clear, and that's that parents in both programs really had a desire for both child and parental involvement, either together in a session or perhaps concurrently in sessions where there's a parent level education program going on and perhaps a more hands-on or practical session for children happening at the same time. Again, this is pretty consistent with literature suggesting that, it is beneficial to have both child and parental involvement when we're looking at certain outcomes. Parents did think that they were more confident in the primary agent of change role, but they weren't always comfortable with this role. And I didn't present some of the data today where parents actually identified, I feel more confident in this, but I still think my kids would receive the information better from an expert than from mom lecturing, coming home and saying, I learned this and this and this, and you should do this and this and this. So there's a bit of tension there around that role. Parents, again, although they identified greater confidence, they did still identify that they did find it challenging to talk about weight with children and health. So perhaps having children in the educational sessions with parents would alleviate some of those parental concerns about communicating program information. But we also know that there may be risks associated with child involvement in a program like this. Risks associated with having a child in a session with a whole bunch of experts addressing an issue or something wrong with the child. And so, there is that balance that we have to consider. And of course, spoken like a true academic, we need more research in that area. Bottom line, in terms of implications, there is still a need to design and implement effective and sustainable treatment programs for the treatment of childhood obesity. We need larger scale experimental designs, longer treatment durations. Anybody working in this area does know that this is difficult for families with lots of different scheduling issues, and because there's also a lot more people who can drop out of a program when you're involving families. Recruitment challenges remain important, particularly for fathers who are underrepresented in this area of research. And so I do think we need to have some greater consideration around efforts to engage and recruit fathers in this type of program, because we do know they also play a critical role in shaping the health behaviors of their children. And I'll end off here, going full circle back to Epstein and colleagues, who suggested, which I think is a reasonable recommendation, that perhaps one way forward is to develop an intensive, full-year, family-based intervention that perhaps uses a summer camp as an initial intensive phase, followed up with parent or family booster sessions throughout the course of the year. Ideally, this would be combined with traditional clinical treatments, as well as community, school, and public health involvement. And then finally, on the basis of our work, I think it needs to be suggested that group dynamics remains paramount. Families have a strong desire to be together and to work together towards change, and I think that as researchers we can continue to focus our efforts here to provide opportunities for children and families. Thank you very much to the families, the funding partners, the community partners, and to the wonderful research team that I am here representing today. Thank you.
We have time perhaps for one question.
Thank you for the great presentation. In the eating disorder area for adolescents, the gold standard of treatment is manualized family-based treatment. It's effective in about 50% of patients who are treated that way. I was wondering, number one, if your approach of the CHAMP has been used for adolescents or if you're planning on using it. And number two, whether or not there's a manualization of the approach of family-based interventions.
Excellent question. Thank you very much. Going to your first question about adolescents, we have not modified or planned to modify these programs for adolescents. We focused on sort of a 6 to 14 age range for both programs, although moving forward, that is something to consider. We also, in terms of the manualized approach, there are different approaches targeting different family-based interventions for different populations that exist, and we actually used one as a template with modifications because it was actually for a younger age group for the parent-focused intervention. We also have plans to continue in that way, you know, creating manuals and things like that on the basis of this work. So, thank you for that. Thank you.
Thanks, Dr. Burke. Next, our next speaker is Dr. Vern De Lenski. Dr. De Lenski is an associate professor of pharmacology at the University of Manitoba. As well, he is co-lead of the Diabetes Research Envisioned and Accomplished in Manitoba, or DREAM research theme, of the Children's Hospital Research Institute of Manitoba. Please join me in welcoming Dr. De Lenski.
Okay, I'd like to thank the organizers for inviting me to give this talk, and I'd also like to thank them for programming this topic, because it's a little bit different than the preceding speakers, but I'm glad they kind of recognized that the early life origins are an important factor contributing to development of obesity. And I'd like to also acknowledge the outstanding workshop that was presented yesterday involving Michelle Matola and Christy Adamo, who kind of introduced this sort of developmental origins of disease framework that is underpinned by a lot of epidemiological evidence, cohort studies, and animal model studies. But obviously today I'm going to specifically focus on some of the animal model studies that underpin this evidence, and more at a kind of a molecular level in this talk. But I would like to also acknowledge that our DREAM Diabetes group is also working with cohort studies ongoing to kind of look at some of this evidence as well. So one of the major factors that links the early life environment to the developmental origins of health and disease in the offspring is epigenetic factors, and that's specifically, I'll talk about that in a little bit more detail now. But one of the major factors, or the most stable epigenetic marks, is DNA methylation, although there are many others, such as histone modifications that alter chromatin architecture. Now, DNA methylation specifically refers to a methylated cytosine that's followed by a guanine in kind of a CPG sequence, and these often appear as islands within the genome that are more frequent in promoter or enhancer regions that are involved in controlling gene expression. And I kind of illustrate this here on this slide. So maybe you can kind of imagine that that double helix that has a DNA sequence is like the words on a page of a book, and the methylation of the DNA is like the punctuation throughout the words on that page that is really kind of guiding and making sense of those words on the page. So if you consider, the double helix in the middle as being kind of the average state of methylation within the genome, you can have either hypermethylated states, as you see on the top, or hypomethylated states. And these are very responsive to environmental cues. And so they are important for regulating gene expression. Another way you can kind of envision this is kind of use the analogy of the light switch. So we often think of polymorphisms or mutations within the coding sequence of genes. And these can actually fundamentally alter the expression of those genes. So it's kind of like turning on or off the light switch. DNA methylation is more of a, to use an analogy, more like the dimmer switch, that you get more of a range of phenotypes or a range of effects on gene expression. So as we move from a hypomethylated state to more of a hypermethylated state, that's typically considered to be more of a kind of a gene repressive mark. But you have to consider this kind of in the genomic architecture of where those methylation states are occurring. Are they associated with repressor elements or enhancer type of elements within the genome? So with respect to the maternal environment, DNA methylation is really established in the fetal stage. So it's very responsive to those kind of environmental factors that are present in the early life environment. And this can influence stem cell lineages, cell proliferation, organ growth, and metabolic control in those fetal offspring. But we also can't consider this to be deterministic of whether you're absolutely going to develop phenotypes later in life, because there is definitely still an interaction with postnatal diet and lifestyle. So really, changing the DNA methylation, those environmental effects on DNA methylation state of the fetus are defining risk factors or the propensity for various outcomes later in life, whether it be obesity, hyperlipidemia, or other complications that are associated with the development of obesity. My laboratory specifically is examining gestational diabetes as a factor in kind of that environmental influence on the development of obesity in the offspring. And so why gestational diabetes? Well, it's probably the most common complication of pregnancy, affecting 5 to 10% of pregnancies at a population level, but higher rates in selected populations, for example, up to 20% in some Aboriginal populations. Now, pregnancy itself is normally associated with weight gain and a moderate increase in maternal insulin resistance. But if there's already pre-existing obesity or overweight in the mom, this greatly increases her risk of developing gestational diabetes. So, we see now that up to 30% of women in the U.S. have overweight or obesity at the time of conception. And then if there's also additional excessive weight gain during pregnancy, that also contributes to the risk of gestational diabetes. Okay. So my laboratory, when I established the laboratory, I decided to develop a rat model of gestational diabetes to really look at the mechanisms underpinning that early life exposure. And so this is associated with hyperglycemia by mid-gestation, as well as excessive gestational weight gain, maternal glucose intolerance, and impaired insulin secretion in the mother rats. Okay, so having this model, this allows us to look at the interaction between the early life exposure as well as the diet of the offspring. So we also, after delivery, we expose the animals to either a low-fat or high-fat diet postnatally. And then we followed the animals throughout their lifespan. Most of the data that I'm going to show you is collected in young adult rats, which we generally define as they're not fully grown, they're just sexually mature but not fully grown, to kind of model adolescent the stage of life. Now what we see on the panel below in yellow shows the weight trajectory in the offspring consuming a low-fat diet, but they're the offspring of the gestational diabetic mothers. And what we see is that they're on a trajectory to have a greater weight gain in this early life period. If we look at the additive effect of or if we look at the effect of a high-fat diet now, just in the lean offspring, we can see that their weight gain is almost equivalent to just being exposed to gestational diabetes on its own. And then if we add on a high-fat diet as well as postnatal high-fat diet as well as gestational diabetes, we can see that there's this additive effect on that weight gain trajectory. The data I just put into this panel here specifically just shows the male offspring, but we see similar patterns in weight gain in the females. It's just not as profound in the early life stage, but it does become much more apparent later in life. And as we can see, if we even track this out further across the lifespan, these trends continue to hold true. And I don't mean to fat shame this rat in the image here, but I'm showing my graduate student, Stephanie Karolak here, is holding one of the male rats towards the 40-week stage here, and you can see that this rat is approximately almost the size of a cat. So you can see that consuming a high-fat diet and gestational diabetes really markedly affects the weight gain in these rats. Further data here, so we also did dual X-ray absorptiometry to look at adiposity, and what we can see there is that definitely gestational diabetes and the consumption of a high-fat and sucrose diet really markedly enhanced abdominal adiposity in those offspring. Furthermore, if we look at glucose tolerance in these animals, what we can see is that the additive effect of high-fat diet and gestational diabetes markedly affects glucose tolerance. In addition, if we look at other complications, we can see that ex vivo here, that the insulin secretion capacity of these offspring is markedly impaired, and it's further impaired by the addition of a high-fat and sucrose diet. We also see cardiovascular complications in these animals. They have a propensity to have an enlarged heart, as we can see here, both at the young adult stage and also at 12 months of age. So this cardiac hypertrophy is in fact also associated with dysfunction. So you might kind of perceive that having a large heart is an adaptation that these animals develop in order to maintain the same level of contractility of their hearts. But on another level, it actually impairs the ability of that heart to relax. And so that relaxation phase is also impaired, as we show here that the diastolic cardiac dysfunction becomes apparent. And this is in humans is also a feature of diabetic cardiomyopathies as well. At a genetic level here, I show these two heat maps here. So what we did was RNA-seq of two different tissues. So we looked at both cardiac genes as well as islet genes, and we saw profound differences that are induced by gestational diabetes in these offsprings, in the gene expression. We also observed that the gene expression profiles, these genes that were affected by gestational diabetes, were quite different in the different tissues as well. So for example, in the cardiac tissues, it seemed that gene expression was more affected at a metabolic level as well as level of various transporters, whereas in the islets, it seemed to be inflammatory pathways. So the kind of the interleukin 1 alpha and 1 beta, as well as their receptors, were more profoundly affected by gestational diabetes. And then we also have done whole methylome sequencing in these offspring as well. And this slide really emphasizes here that the DNA methylation states between the gestational diabetes offspring and the lean offspring are quite markedly different. But there's also additive effects with having a high-fat diet exposure as well. So there are profound differences there as well. So just to summarize what I've presented today, what we see is that in rats, in utero gestational diabetes exposure condition the propensity for obesity in the offspring, as well as various obesity-related complications. Gestational diabetes also induced changes in DNA methylation gene expression that could influence the development of obesity and obesity-related complications. And this is important just for the knowledge that we can, by changing these, epigenetically changing these gene expression, we're perpetuating a cycle of obesity and obesity-related complications. But this also provides kind of a way that we can maybe change or shift this cycle by intervening in early life or intervening in pregnant women to kind of change that trajectory for development of obesity and gene expression. So I would like to acknowledge my laboratory here pictured and all of the individuals highlighted in yellow or in red there who contributed to the studies that I presented here, as well as all my collaborators, in particular the individuals I work with on the clinical side who are kind of doing matching epigenetic studies in that realm, especially Dr. Alison Dart, Brandy Wicklow, and John McGavick there as well. Thank you for your attention. Appreciate it.
Thanks. We have time for 1 or 2 questions.
I apologize in advance if it's a dumb question, but my question is about epigenetic modification of gene expression, and you said that you see that by changes in methylation. Is that an irreversible process? Are the effects of gestational diabetes on epigenetic modifications? Can you do anything to change that? And are there things that happen during the course of a lifespan that also modulate the epigenome?
Mm-hmm. No, that's an excellent question. So I'm glad you asked that. So DNA methylation itself is considered to be quite a stable epigenetic mark, but that does not mean that there's specific windows where the methylome can be modified and altered. So I did highlight in my talk that obviously the fetal stage is a very important stage because that's when a lot of those epigenetic marks are established. But there are also specific windows when the epigenome and DNA methylation specifically is also particularly malleable. And that's in particularly in infancy, especially that 0 to 2 years of age. And it's thought that in particular period when there's breastfeeding ongoing is potentially a window when there's also possibility to modify the epigenome. Puberty is also considered to be a stage when the epigenome is also malleable and can be changed as well. And also, just interestingly, that's also a stage when a lot of overweight or obese children typically also tip over into becoming or developing type 2 diabetes. And so there may be kind of an interaction there that needs to be studied and characterized, and offers an opportunity to also intervene as well. So it's a great question.
We'll take one more last question.
Thank you very much for your talk. Just a question whether you are aware or you have done in your lab any investigation looking at methyl donors. Folate's recommended in pregnancy. It's a methyl donor. And wondering if you've ever looked at physical activity, metformin, or insulin, and the effect on methylation and then susceptibility to high-fat diet in the offspring.
Great questions there as well. So essentially in the animals that we're studying, there's no folate deficiencies that are going to be apparent. We've also specifically looked at, obviously, folate supplementation is very important in pregnancy. And we've also looked at whether any of those particular pathways or genes might be that control methyl donor production are changed in our animal model, and they are not. So we've sort of ruled that out as a potential. There are various studies and ongoing as far as looking at how whether exercise or other interventions can kind of modify the epigenome. Some of these studies recently reported of Suzanne Ozanne's laboratory, for example, at Cambridge University have looked at this, and they've identified some marks that are modified by maternal exercise, metformin administration. We're also very interested in this space as well, and are also investigating this in an animal model system as well, but nothing yet to report on that from our group. Thank you.
Okay, thank you so much to our great speakers that we've had this morning. And starting right away, we'll have Pecha Kucha sessions, so I hope that you guys will all stay for that. Thanks so much.
Good morning, everyone. Can I invite all the Pecha Kucha speakers to the front, please? All right, good morning again, everyone. So welcome to the Pediatrics Pecha Kucha. I'm Nadia Brown, and I'm a PhD student at the University of Alberta in the Department of Pediatrics, and I'm also Obesity Canada Students and New Professionals Vice Chair. So this morning, for those of you who don't know, a Pecha Kucha is a short but yet an engaging presentation. Each presenter has approximately 7 minutes to present using 20 slides, each 20 seconds long. So because the presentations are short, we're asking everyone to refrain from asking questions. Each speaker has a complimenting poster outside this room, so feel free to pass by after and ask them any question that you want. So our first speaker this morning is Kristen Zahn from McMaster University. Please join me in welcoming Kristen.
Hello, everyone. My name is Kristen, and I'm a pediatric resident at McMaster University. Today, I'm going to be talking to you about the characteristics of programs that are participating in the CANPWR study, which you heard Dr. Morrison speak about earlier. And we're going to look at the trends of the characteristics over the period of recruitment. As we know, childhood obesity is a significant public health concern, affecting 1 in 3 Canadian children. We've spoken about the vast physical and mental health consequences of childhood obesity, and interestingly enough, children with obesity have actually reported a similar quality of life to those with childhood cancer. Let's talk about pediatric weight management programming. What do we know? We know that in the last 10 years, there's been an increase in pediatric weight management programming, and we also know that the basic general principles include family engagement, multidisciplinary teams, as well as multiple interventions that look at physical and sedentary activity, diet, and exercise. That brings us to CANPWR. CANPWR is a Canadian Pediatric Weight Management Registry, and this is a multi-center prospective cohort study of around 1,300 participants at one of 9 Canadian sites. Children are enrolled in CANPWR at enrollment into their pediatric weight management program, and you can see these are the 9 sites across the country. CANPWR objectives look at documenting anthropometric, lifestyle, behavior, and obesity-related comorbidities over the 3-year period, with data collection at 5 time points in the program. It's also looking to characterize individual, family, and program-level determinants of change and program attrition. This brings us into the portion of CANPWR that I'm going to be talking about today. I looked at comparing the clinic characteristics at the start of recruitment and at the end of recruitment and described the changes over time. Surveys were given out that looked at various program characteristics, including referral process, eligibility criteria, and various staffing models and interventions. The 3 main aspects that I will be talking about today are eligibility criteria, which encompasses age and health status, staffing models, which looks at full-time equivalent and direct patient care providers, and interventions, including length of duration and type of intervention. Within eligibility criteria, the first thing I'll talk about is age. We can see that over the period of recruitment, there's been a small shift to more generalized age criteria in clinics, with 2/3 of the clinic accepting patients at a lower age limit of 0 to 2 and an upper age limit of 17 to 18. We can see that there's still 3 clinics who accept school-aged children. With regards to health status, these are various applicabilities that programs can click off of what they take as far as health status, and most children accepted were either into the BMI of over 85th percentile or over 95th percentile. There also has been a small change over time with more generalizability, and one program accepting children with no criteria of health status. There are 2 specific circumstances where programs were quite specific in what they accepted, and one, as you can see, was a BMI over the 95th percentile with obesity-related health consequences, and the other was age 10 to 17 or under 10 with obesity-related health consequences. With regards to clinic staffing models, we can see here the change over the period of recruitment. There has been an increase in exercise specialists, dietitians, and psychologist service over recruitment, with a decrease in nursing and physician, and a little bit in admin and research staff. It was also interesting to see that over this period, there was an increase in the total number of full-time equivalent staff with regards to the clinics, and this may be due to increasing growing size. When you do the math and move out to full-time equivalent staff per patient per enrollment year, there is a wide variability, almost tenfold between the clinics, with the average being about 0.05. With regards to direct patient care providers, at the start of recruitment, all clinics had physicians, 8 out of 9 had dietitians, 7 out of 9 had nursing specialists and exercise specialists, with 6 out of 9 having psychologists, 5 having social work, and none having occupational or physiotherapy. There was a large variability in change within the clinics over the period of recruitment, but at the end our numbers showed a change when exercise specialists with an increase of 1 from 7 to 8 out of 9, and 1 clinic also adopted a physiotherapist. This is consistent with the Canadian Clinical Practice Guidelines and what's recommended. Moving on to intervention duration and length of follow-up. At the beginning of recruitment, there was 7 out of 9 programs that had an undefined length of intervention, with 1 program having 10-week and 1 having 104-week. At the end of recruitment, this was decreased to 4 programs, with most of them falling in the 104-week duration. These are the various types of interventions that were studied. With regards to lifestyle coaching counseling, all programs started with this, and 8 out of 9 ended with this. Just under half the programs adopted a structured exercise plan, and 2 programs started with pharmaceutical management, and 1 finished with it. This is looking at those programs who did supervised nutritional intervention and exercise treatment in addition to counseling. So these are things like cooking classes, grocery shopping, and exercise classes. Just under half the programs, 4 out of 9, started with both of these things. And at the end of recruitment, there was the same number for nutrition and 1 less for exercise, although they may have been actually outsourcing some of the exercise classes. As we can see, there's a large program variability across Canada in the CANPWR sites, with eligibility criteria becoming slightly more broad and generalized over the period of recruitment in both age and health status. With regards to staffing models, we did see an increase in the number of full-time equivalent staff, and these are in keeping with the Canadian Clinical Practice Guidelines. If you compare this to the adult literature, we actually seem to be a little bit more well-staffed in pediatrics than adults, and this may be because we're usually run out of tertiary care centers. Intervention duration varied greatly and is likely to be influenced by government funding. I would like to thank all of you for listening today, as well as the CANPWR participants and families and the co-investigators that are listed there, as well as the various funding sources.
Thank you, Kristen. Our second presenter this morning is Marcus O'Neill, and he will be presenting on youth and parent motivation to change lifestyle habits, preliminary findings from the readiness and motivation interview for families. Please help me in welcoming Marcus.
So I'd actually like to begin my presentation by painting a picture of a scenario that most clinicians and researchers working in pediatric weight management are probably familiar with. In the scenario, a family arrives for their first appointment at the clinic. It is a teen accompanied by both his mom and dad. You can tell that at first glance, not everyone is excited to be here. As you approach mom, the mom turns to dad to tell him to put his cell phone away before smiling hello. The teen doesn't make eye contact with you though. Over the next 30 minutes of the appointment, mom asks a lot of questions. It's obvious to you she's quite keen to learn more about how to manage her son's weight. Dad asks a few questions too, but really it's mom who dominates the conversation. The teen himself says little throughout most of the appointment, and it seems like he'd rather be anywhere but here. At the end of the appointment, you provide your recommendations, say your goodbyes, and the family leaves. In your opinion, it's difficult to say whether they will return for their follow-up visit next month or not. So as illustrated in this scenario, motivation is an incredibly important factor to consider as it relates to weight management. Based on previous work done by our group, motivation to change lifestyle habits plays a pivotal role in treatment engagement and termination. Motivations can also obviously vary amongst family members. As I'm sure anyone who's a parent can attest, parents don't always see eye to eye with their teens. This may be particularly true when it comes to things affecting one's long-term health. But assessing motivation can be tricky. Despite guidelines encouraging clinicians to assess motivational factors prior to initiating therapy, there is no established tool that helps determine motivation in teens and families in weight management. So the Readiness and Motivation Interview for Families, or the RMI family, was created to help address this limitation. The RMI family is a 30 to 60 minute structured interview that builds off work by Dr. Josie Geller, a co-PI on this project, who developed and tested the original RMI for use in the treatment of eating disorders in young people. The RMI family assesses parent and teen motivational factors, including the perceived importance of and confidence in changing 6 different lifestyle behaviors. These 6 lifestyle behaviors include physical activity, screen time, sleep, eating treat foods, overeating, and eating when not hungry. In keeping with the client-centered approach, motivational interviewing techniques are used during the RMI family. This means that interviewers are trained in MI to take an open and non-judgmental stance when asking their questions. MI has been shown to help build rapport and resolve ambivalence about making changes to unhealthy habits. In terms of the study itself, we have 2 main objectives overall. First, we want to examine the reliability and validity of the RMI family as a measure of families' motivation to change lifestyle habits and the agreement between family members. And second, we aim to determine the predictive value between the RMI family motivation and outcomes such as lifestyle habits, weight, and program attrition. In terms of recruitment, we are currently recruiting from 2 multidisciplinary clinics in Edmonton and Calgary. Families are eligible to participate if they have 1 primary caregiver and 1 youth who is 13 to 17 years old. Both family members must be fluent in English, and the teens must have a BMI greater than or equal to the 97th percentile. Families in the study are followed for 1 year. We meet with the families when they begin treatment and follow up with them again at 6 and 12 months to complete their RMI family interviews, which are conducted separately for both the parents and youth. At each time point, participants also complete psychosocial questionnaires, including motivation to change rulers. And as well, we collect additional demographics, basic anthropometrics, nutrition, physical activity, and health services usage data. So now I'm going to move on to discussing some of our early results. A quick note is that I'm only going to be discussing results related to our participants' baseline visit only. At present, we've recruited 25 families. The primary caregivers were mostly female. 70% of them had a BMI greater than 30. The teens were almost evenly split between male and female, and the vast majority were above the 99th percentile for BMI for age. In the course of the RMI family, both parents and teens are asked to rate their perceived importance of teen lifestyle habits. Parents rated physical activity, screen time, eating treat foods, overeating, and eating when not hungry higher than the teens themselves. However, there were no differences between parents and teens when it came to sleep. When we looked at parent and teen readiness to change, each of the lifestyle habits illustrated on the slide here, we found that parents' readiness to change was significantly higher than teens for all of these lifestyle habits. So taken together, these preliminary data show that at baseline, parents tend to place higher levels of importance and readiness to change teen lifestyle habits than the teens themselves do. Anecdotally, this is probably not a huge surprise, but we are interested to see if this relationship holds as we follow families over time, and whether or not it matters in terms of their clinical outcomes. As for what's next, we will continue to recruit new families into the study throughout the year and into 2020. Our goal is to 100 families total, so we still have a little bit of work to do to get to that. We will also continue to do our 6 and 12-month follow-ups, and we have actually done a fair amount of these to this point. So in the end, we all know that motivation to change behavior is important. Our hope is that the RMI family will provide value to clinicians working in pediatric weight management and help guide treatment, such that the family we met in this scenario at the beginning of this presentation is indeed more likely to return for their follow-up visit. So finally, I'd just like to take this opportunity to thank all of our team members, particularly Dr. Jeff Ball and Nadia Brown, and not just because she's up here right now, for their guidance and support. As well, I'd like to thank all of our supporters and funders too. And I'll be happy to take any questions at the poster session afterwards. So thank you.
Thank you, Marcus. Our next presenter is Anik Buckles. She's from the Children's Hospital of Eastern Ontario. Help me in welcoming Anik.
Good morning. I'm Anik Buckles. I'm a clinical psychologist at the Center for Healthy Active Living, CHAL, here in Ottawa. And I'll be talking about our study looking at health trajectories of children with severe obesity attending a tertiary care weight management program in Ottawa. So left unmanaged, children with severe obesity are at risk for medical conditions such as cardiovascular disease and type 2 diabetes, as well as mental health conditions such as anxiety and depression. Current limitations to weight management programs and research is that we have few longer-term outcome studies. RCTs have important enrollment biases, and there are very few studies with mental health outcomes. So the purpose of our study was to examine both physical and mental health trajectories of change in youth with severe obesity attending tertiary care over 24 months, And our hypothesis, based on previous literature, is that younger children would show more favorable outcomes. Our inclusion criteria were children with BMI greater than the 99th percentile for age and sex, or with BMIs greater than the 95th percentile with a medical comorbidity. And our program is interdisciplinary, family-based, and uses a health at every size framework. And the stated goals were to improve quality of life and health of the children and families we serve. I don't have as many pictures, I'm sorry. We approached 217 consecutive families, and of those, 209 agreed to participate in our research program. That's 96%, and after 24 months, 83% of our families were still enrolled in the research program and in our clinic. So this was a 2-year observational longitudinal study. The mean age of our kids was 13 years. Mean ZBMI score was 3.96, and 28% of our families reported incomes under $50,000. Our key variables were ZBMI scores, non-HDL scores of depression as measured by the CDI, anxiety as measured by the MASC, PEDSQL as measured by the, quality of life as measured by the PEDSQL, and measures were taken at baseline assessment, 6, 12, 18, and 24 months. 89% of the children presented with one or more physical comorbidity, with hyperlipidemia being the most prevalent, and 58% presented with a significant mental health condition, with learning disorders being the most prevalent. Taking a look at our baseline statistics, we found it interesting that ZBMI correlated very poorly with our physical and mental health indicators of health. Take that in. Our analyses were multi-level linear models, which showed change in BMI, cholesterol levels, depression, anxiety, and quality of life. And we controlled for household income, program participation, and we looked at variations in age, sex, and distance from our program. So here's our primary results. Looking at quality of life, we found significant improvement in quality of life as reported by both children and their parents over the 24 months. The middle dashed line is that of the youth, and you can see that they are approaching community norms, community means. BMI trajectories were more varied. The top dashed line is our younger cohort. They are starting off with higher ZBMI scores and showing significant improvements over time. The middle dashed line is our younger adolescent cohort with a median age of 12, and we are seeing stabilization of trajectories over time. And the lower line is the older teens, which are showing small but significant increases over time. With regard to cholesterol, as measured by non-HDL, we found significant decreases over time for all age groups and in boys and girls. We also found significant decreases in depression scores over the 24 months, with clinical concerns on the CDI decreasing from 14.3% of children to 6%, whereas anxiety was found to be more stable over time. Boys and girls, children of all ages, families living near and far from CHAL changed at about the same rate over the 2 years on measures of non-HDL, depression, anxiety, and quality of life. Future directions, we need longer-term outcome studies in pediatric weight management. We need research with fewer exclusion criteria. And we need to include mental health frameworks and indicators of mental health in our research. In conclusion, we found parallel improvements in physical and mental health outcomes, and our study provides preliminary evidence for family-based weight management programs with a health at every size framework with a focus on mental health and positive body image. Thank you.
Thank you, Anik. Let's welcome Karen Strange from the Childhood Obesity Foundation.
Good morning, everyone. I am the project director for the Family Healthy Living program, and today I'm going to present some of our preliminary findings on the impact of the program on the behavioral profiles of the children that participated in our first program cycle. The program is delivered in partnership between Childhood Obesity Foundation and the University of Victoria, and it is funded by the province of BC. The program was developed after an intensive stakeholder consultation process that occurred between November 2017 and February 2018, and our first program was offered in September 2018. The Family Healthy Living program is identified as an early intervention program, and early intervention is one of the 6 components within BC's continuum for the management, treatment, and prevention of health issues related to overweight and obesity in children and youth. And so it's a program that is designed before a clinical intervention is required. The program is delivered through municipal recreation centers and YMCA facilities. We had 6 communities delivering the program in fall 2018. It's a 10-week program that's for families with children between the ages of 8 and 12 years old who have a BMI above the 85th percentile for age. The program includes both family physical activity opportunities as well as child-only opportunities, opportunity for parents to have parent-only discussion as well as family discussion time, and there's interactive positive mental health activities as well as healthy eating activities. We also provide access to a family portal for the families. There's a weekly lesson as well as recipes, family activity ideas, and a discussion forum where participants in the 6 programs can communicate with each other. So the objectives of the study I'm going to present today is to measure the behavioral profiles around healthy eating, physical activity, sedentary time, and sleep for the children that participated in the program, as well as looking at some of the parental support. We did anthropometric measures as well as questionnaires with the children, both at baseline and at the end of the 10-week program. We also had the parents complete questionnaires pre and post the program. And we did this with the children. We set up a health fair where they had a number of different stations that they went to, integrating the measurements among some fun activities. In terms of promoting the program, we used a number of mechanisms to recruit families, and as we all know, recruitment is difficult for programs like this. We found the number 1 way that families found out about the program was through social media, and particularly Facebook. In terms of the demographics of the families that took part in the program, they came from diverse backgrounds related in terms of education, ethnicity, and socioeconomic background. And majority of the families were 2-parent households. Girls and boys participated essentially equally in the program, and the majority of the children that participated in the program were above the 97th percentile BMI for age. So in terms of results, for physical activity, what we found is that the children that participated in the program increase their motivation, competence, and confidence for physical activity. So their motivation to participate in physical activity, their competence, particularly in group activities, and then their competence in participating in physical activity time. And this was also reflected when we assessed their physical literacy skills. So we utilized the Canadian Agility and Movement Skills Assessment, and the children increased their score, indicating that they've increased their physical literacy. We asked the parents about the child's quality of life, and what we found is that after the 10-week program, parents reported that their children had increased quality of life, particularly around emotional aspects, interacting with their peers more, and being more engaged in the school environment. We also found that the parents that participate in the program increased their confidence to support their children and their families, particularly in the areas of structuring the home environment, so being able to increase their opportunities to provide fruits and vegetables and to reduce sugary drinks. We also found that they increased their support for physical activity, both in their ability to provide physical activity opportunities for their children and families, but also in their role modeling around physical activity. In terms of sedentary behavior and screen time, although we didn't see any difference in their actual sedentary behavior time or time on a screen, we did see that the children increased their confidence to address their screen time. So hopefully with a longer time period, they'd actually be able to change their time on the screens. Again, in terms of healthy eating and healthy eating, we looked at fruit and vegetable intake as well as sugary drink intake, and we did not see any difference between the baseline and 10 weeks post with the children. So in conclusion, we did see a number of changes in the children, particularly related to physical activity, and this makes sense when we look at the structure of the program. The greatest emphasis of that 10 weeks is with the children is around physical activity. And because we didn't see changes in the healthy eating, we know that we need to incorporate more interaction around that in the program. So thank you for the opportunity to present this data. We have a poster as well as a table where you can come and ask questions. Thank you.
Thank you, Karen. Let me thank all the speakers for their brief yet engaging presentations. Each speaker here this morning will have a poster outside, so they'll be there from now for at least half an hour. So feel free to go outside and ask them as many questions as you want. Lastly, judges, I'll be collecting your sheets, so I'll pass by and do that. Thank you, everyone, for coming out to this morning's Pecha Kucha.